Hello. Right, Celia says hello from Edinburgh. We are live in the room. We appear to be live on Facebook. We are up and running. Okay, good afternoon, sir. How are you?
I'm very well, and it's either good news or bad news, depending on your perspective, that you've got an extra special guest appearance by me. So,
Not seen you in ages.
so
No,
I shall leave anybody else to decide whether it's a good thing or a bad thing.
certainly not for us to decide. No, for me it's a good thing, always. So thank you, and we're grateful to have you. Right, if you are here on Facebook watching live, if you are in the room, it is really nice to have you here. Welcome. Thank you for joining us on our weekly Q&A sessions. So questions are always welcome. Anything you want to ask, then feel free to ask. Do bear in mind, however, that what we do here is about general medical information. It's never about medical advice. And it should not replace the conversation you have with your own clinician, but should certainly enhance it and improve it. And those are the intentions for today. So thank you and welcome.
Robert, actually, I keep meaning to just add a comment to what you say correctly there. And
Please.
the reason is that the sort of comment we give is the sort of thing that would be applicable on average to 100 people with the particular story that we hear. So on average, it's correct. The problem is once you get to the more individual, then it becomes very nuanced. And there is other information that we don't have around individual people. So that's why, a consultation in the hospital takes as long as it does, because there's a lot of information that you need. And there is also a backstory. So whenever we see people in the clinic, we have their historic records, we have their blood tests, we have a complete picture. So in medicine, you try and avoid snap observation. So it's general advice. For an average person, it's going to be accurate, but we're not all average, we're all individuals. So that's the reason it's difficult without knowing the whole story.
Okay, perfect. That's most helpful. Thank you very much for adding that comment in, because that is most helpful. Okay. Can we start with PBC and?
A favourite round.
Okay, here we go. So I've got an absolute cracker. So we're 3 years down the line. I've never experienced this word. I'm going to take a stab at it, okay? Just for the sport. I'm going to say laryngopharyngeal reflux, which apparently is known as LPR. Is that common with PBC patients?
So I'll assume we're talking about acid reflux going up into, it's not a term that I'm familiar with, but I will assume we mean acid reflux ending up in the upper airway. So forgive me if we're not talking about that. So this is where I talk about how giraffes drink water, which is a semi-philosophical thing we've talked about, I think, before, which is that our gut relies on coordinated contraction and relaxation. So food goes through our gut by the gut squeezing it through, a bit like sort of squeezing toothpaste. And it doesn't really rely on gravity, interestingly. And the ultimate example of this is how do giraffes drink water, because they stick their head into the water and yet their stomach is sort of 6 feet in the air and the water gets squeezed up the esophagus. So our esophagus squeezes and then it relaxes in one bit and relaxes in the next bit in order to milk the food or the fluid through. Now, there is one bit of the esophagus that works in a different way to that, which is what's called the lower esophageal sphincter. So this is the muscle that is the bottom of the esophagus, between the esophagus and the stomach. And that relaxes when the rest contracts, and it contracts when the rest relaxes. So it's normally contracted and it relaxes to let food through. So normally it's the other way around. So it does it there's a sort of a way that it prevents that from happening. Now, the reason why we have that is because the acid that our stomach produces, the acid from that our body produces in the stomach is actually very irritant. So it's enough to burn the skin if it gets onto the skin. So clearly that's going to cause problems if you don't allow it to be controlled. Okay, so there are two ways our body prevents acid from causing problems. One is to have a coating on the stomach. So there is a coating on the lining of the stomach that keeps the acid out. So there's a sort of layer of mucus that keeps the acid out. And the other is by stopping the acid getting into places you don't want it to go to. So one of those is that you don't want it in the esophagus because the esophagus hasn't got the lining to prevent it. So that's what that sphincter does. It clamps shut normally, stops acid getting up. And there are various different situations when that becomes not as functional and the acid then ends up being able to leak up into the esophagus, and it can cause heartburn or it can cause some scarring in the lower esophagus. So it can be quite an unpleasant symptom. So what causes that? Well, it can happen with what's called a hiatus hernia, where you've got a little bit of the stomach has ended up in the chest. It can happen if the abdominal pressure is higher than it should be. So if people are a little bit overweight or straining when opening their bowels, that can squeeze acid up. There are some medicines like amlodipine and nifedipine that dilate the sphincter a little bit. And so there are a number of different things that can cause that to happen. In PBC, there are two things that are probably relevant to this. The first is that probably that sphincter is a little bit relaxed because of the effect of urso in general. So I think we probably do see more reflux in people than we would tend to. And then the other one is that actually our saliva that we normally produce is a little bit alkaline. And for those people who remember their kind of chemistry lessons, acid and alkali balance each other out. And so the acid in the stomach, if it gets into the esophagus, is normally neutralized by the slightly alkaline saliva. And as we've talked about on many occasions, people with PBC don't produce as much saliva. So normally that causes mouth problems, but in some people it will mean you can't counteract a little bit of acid production. So it's probably a little bit commoner for a variety of reasons, and it shouldn't be a problem because it's really, really straightforward to manage with the newer, I mean, not so new, but the sort of really effective acid controlling tablets like omeprazole, lansoprazole, pantoprazole. What they do is simply reduce the amount of acid production. So it isn't anywhere near the problem it used to be. If it's getting up into the larynx, if it gets right the way up, this is where people might cough and splutter with it, have a very bitter taste in the mouth. It can leak back into the lungs, and it is a weird cause of asthma and chest infections. So if people are getting recurrent chest infections or they're getting asthma attacks when they're lying flat at night, it's sometimes acid creeping up and then going into the lungs. And so have I solved somebody's asthma by giving them acid controlling tablets? I certainly have. So it's not the cause of asthma in most people, but it is an important and treatable cause of asthma. If that is what's happening, it is acid control is what you do. You don't try and control the sphincter, just stop the body producing acid. But it's an unpleasant condition, but it's just a lot easier than it used to be. And it's probably a little bit commoner in PBC. But it doesn't really matter because you treat the problem and the problem's easy to treat.
Okay, perfect. Thank you very much. Helpful. In the same vein, LDH, lactate dehydrogenase, is being shown to be raised in a test.
Yeah.
Again, is this a marker for tissue damage? Is it related to PBC?
Okay. So lactate dehydrogenase is an enzyme. So a lot of the blood tests we use in liver disease are proteins. They're enzymes that are released by cells. So enzymes are the kind of they're the machines that help a cell work. And they're released when cells are injured into the blood. And you can then measure the levels. And if more cells are being injured, so the level of them goes up. Now, it's normal to have these enzymes in the blood, even though they're normally in the cells, because all our cells die and regrow. None of us have a single liver cell we had 6 months ago because the liver renews itself all the time. So it's normal to have some cells die and some cells grow. And so it's normal to have some levels of these enzymes in the blood. So being able to detect them isn't an abnormality, it's just normal. The question is it higher than it should be? Now, the common one everyone thinks about is alkaline phosphatase, which is at the heart of monitoring PBC, which is released from the cells of the bile duct, amongst other cells, and it's elevated in PBC. And we know that if it's elevated more than the normal level, it's part of the disease process. So it's what we call a liver function test. In fact, it's measuring liver injury. So these are things that we look at all the time. ALT, is alanine transaminase. ALT is one that's looked at in autoimmune hepatitis, and in some people PBC overlap. So these are commonly measured. So lactate dehydrogenase is another of these enzymes that's released into the blood by cells that are injured. And it is released by liver cells. So it is the equivalent of alkaline phosphatase in many ways. So in a PBC patient with an elevated lactate dehydrogenase, that is just something you can see as part of PBC. So why have you never heard of it, and why have I never mentioned it in 3 years? We've never talked about it once in the time we've done that. The reason is that unlike a lot of these tests, it's released by quite a lot of cells. So it doesn't really help you know where the problem is. It's a bit non-specific, a bit like a temperature, tells you something's going on, but doesn't really tell you what's going on. So, and in particular, it can be released by cells in the heart. So it goes up in somebody having a heart attack. So if somebody's elevated with PBC, I'm not saying you're having a heart attack, but it can be. And when I was a lad in about the 12th century, in working on a coronary care unit, we used to use that as a blood test for people having a heart attack, but it kept being elevated. Lots of people who weren't having a heart attack because they had things like PBC. So it's a bit non-specific, and it can also be elevated in some blood cell problems. So it's one of these things. There's a thing called the ESR we've talked about on these sessions, erythrocyte sedimentation rate. That's a sort of another of these non-specific tests, and they don't really help very much because they can be elevated in other situations. So what I would say is not to be worried about it, but just to ask the doctor, are they certain this isn't some other cause for it? But it's difficult to prove a negative. So it could be the PBC, but it also, could conceivably be something else. But unless if you've got other health problems, then it's possible. But you never diagnose a heart attack in using these sort of blood tests without somebody having chest pain, if you know what I mean. These are not markers that would occur silently in people, but the chances are in PBC, it's just part of the PBC, like alkaline phosphatase.
Perfect. All right. Thank you very much. That's helpful.
Oh, okay. Just to say, like alkaline phosphatase, having these things in the blood is of no harm whatsoever. So just having it there, it doesn't do anything. They don't do anything. They're not harmful. They're not beneficial. They're just there. And so the only significance is does the level indicate something going on? It's not in itself harmful.
Okay, perfect. Thank you. Okay, still in the PBC and section, we've been asked if there's a link between PBC and either and both vitamin B12 deficiency, and or pernicious anemia.
Okay, so Robert, I'm going to ask you a question. In all these 3 years, I've never asked you a question. Okay, so I'm going to ask you a medical question now. Is the relationship between vitamin B12 and pernicious anemia? Oh, this is sweet revenge. After all these years and all these questions he's asked me, I've asked him one. Is there a link between vitamin B12 and pernicious anemia?
I think there is.
Yes, there is. They are inextricably linked. Okay.
Okay. Yeah.
So.
See, I listen and pay attention sometimes.
Yes. This is great. And the answer is yes, both are linked to PBC. So it's a triumvirate. Okay.
Yeah.
So what's vitamin B12? Vitamin B12 is essential for making red cells. So it's a vitamin, as its name suggests, but you need to have it to make red cells. So without it, your body can have all the iron it needs, but it can't turn it into hemoglobin. Okay, so you need to have vitamin B12 to make hemoglobin. Okay, you also need folic acid to make hemoglobin. So if you are lacking in folic acid or B12, then you struggle to make red cells, and there's a characteristic form of anemia. Okay, where it's B12 deficiency, that characteristic form of anemia, because you are lacking in B12, is called pernicious anemia. And it was pernicious in the sense that it didn't respond to treatment when treatment was cod liver or iron tablets or Guinness or whatever people used to use, right? It's a really horrible term because it actually isn't pernicious in any way, shape, or form. It's in fact the easiest form of anemia to treat. It's just when the term was christened, it wasn't. So I hope it's one of those terms that we really should look at changing. But if only people change the names to make them more fitting with modern things. If only there was a good example of the name of a condition being changed to make it more suitable. So pernicious anemia, don't listen to the term. It's not a great term. For those of you who haven't cottoned on, PBC name change was done for exactly that reason. The name didn't fit with our current understanding of the condition. It was itself a problem. So that was what I was alluding to. So, you can change names if it's helpful to people to do that. And pernicious anemia is just a horrible term. So it's B12 deficiency. Okay. Now, the thing just to know about B12 deficiency is that it isn't only red cells and hemoglobin. Okay. You also need B12 and folic acid to help the nerve system function normally and develop normally. Okay, and this is why people have heard of folic acid, because everyone here will have heard of folic acid in the context of pregnancy and taking folic acid supplements. And that's done to prevent the baby, when you're pregnant, developing spina bifida, which is a failure of development of the nervous system. So that tells us that the nervous system needs B12 and folic acid. So it's important that the levels are normal, both for the blood production, but it's also important for the nervous system working normally. So it is important to get right. So you're short of folic acid. What do? You take folic acid tablets, or you eat more spinach, because that has lots of folic acid in it, and that's really simple. So what do you do if you've got B12 deficiency? Well, you should eat more B12, and that will work. And that's why medicine is kind of an art and not a science, because it will have no effect whatsoever. Because if you're short of folic acid, it's because you're not eating enough in your diet. If you're short of B12, it's almost never because of it being short in your diet. It's because your body can't absorb it. And the body can't absorb it because it needs a protein produced by the stomach called intrinsic factor to bind it, to carry it into the cells in the small bowel. So if you've got B12 in your diet, but you don't have intrinsic factor, then you can have all the level of B12 you want in the world, then you're not going to be able to absorb it. It just passes straight through. And you don't produce intrinsic factor if you have an inflammation of a particular type in the lining of the stomach, which gets rid of the cells that produce it. And that is another type of autoimmune condition. So we talk about PBC being autoimmune because the immune system is targeting you. That's why you have the anti-mitochondrial antibody that people are very familiar with. That's a sign a body producing an antibody against itself. Well, exactly the same thing happens in pernicious anemia. You produce antibodies and an immune response against the cells in the stomach that produce intrinsic factor. So you don't produce intrinsic factor, you can't absorb B12, you become anemic, and you have the neurological problems. And that's why it was pernicious, because it caused real problems. But now it's easy to treat. So how do you treat it? Do you just give B12 tablets? Well, no, because that's not going to work, is it? Because you're not short of B12, it's that you can't absorb it. So what we do is give people B12 injections. And that's why you have a 3-monthly B12 injection if you've got pernicious anemia, rather than taking B12 tablets, because the problem is you can't absorb it because you don't produce intrinsic factor. And we know that because PBC, the basic thing that puts you at risk of getting PBC is the immune system being prone to these autoimmune conditions. And we know that once you've got one of them, you're likely to have another. So pernicious anemia is not common in the population. It, however, is commoner than it should be in PBC patients. And once you've diagnosed it, in truth, you don't need to do anything at all other than just get regular B12 injections. But once you need B12 injections, you're going to need them for the rest of your life, because it's never going to come back. And you can't do it with diet or tablets or anything, because it's not the levels that you take that is the problem. So that's pernicious anemia. It never has a condition needed marketing change more than pernicious anemia does. It's a horrible, horrible term. There you go.
Perfect. Thank you very much. So I've just got a follow-up comment on Facebook. I have erosive gastritis.
Yeah.
Treated for H. pylori last October. B12 was just above the lower end,
Yeah.
but nobody wants to acknowledge this. My gastro closed my case after scope, diagnosed with biopsies. Not even a call or not to GP. I'm looking into self-treatment, though we didn't hear that. So, okay. Just a comment more than a question, but anything you've got on that?
Yeah, okay. So, right. So, erosive gastritis is where you've got some inflammation in the stomach, falling short of an ulcer. So in the old days, gastric ulcers, if you've got inflammation in the lining of the stomach that is not an ulcer, but it's kind of on the route to that, that's what's called an erosive gastritis. Okay. Now, many people will have heard over the years many different theories as to why people have ulcers. Is it stress? Is it smoking? Is it blood groups? It was one of those. It was one of those kind of memes, wasn't it? The highly stressed businessman developing an ulcer, and there were all of these theories. And of course, all of them became entirely redundant when we discovered the actual cause of ulcers, which is an infection with a bacteria called Helicobacter pylori. And it's how these great, and it is important that, you know, medicine can get this completely and utterly wrong. And we got ulcers completely and utterly wrong. I haven't seen an ulcer in somebody for 5 years. And yet when I was a junior doctor, we would have 5 people with an ulcer coming into hospital a night. Okay. It's just disappeared largely as a problem. Why? Because we understand the cause and we can treat the cause. So it is one of the most underappreciated kind of real advances in medicine, but it also shows all of those years people had all this research got it completely wrong. So Helicobacter is a very simple infection, and it's very clever. It's found where is the place you can hide from the immune system. Well, it's in the lining of the stomach, because the immune system is damaged by the acid, but the bacteria walls itself off from the acid, and so it just hides away. Therefore, it produces lots of baby Helicobacter bacteria, and you know it's incredibly successful. And in the days before appreciating it, once you got it, you would have it for life. But one of the things that it would do is damage the lining of the stomach, so that it was more susceptible to acid injury. Okay, so it made the lining of the stomach more vulnerable to acid, and so therefore it would predispose to ulcers. And so once you know somebody has Helicobacter, you give a 1 week, literally a 1 week course of a couple of antibiotics plus an acid controlling tablet, and that will get rid of Helicobacter for life for most people. It's quite extraordinary, and it's a sort of healthcare miracle. Now, if you have erosive gastritis, what it will do is damage those cells that produce intrinsic factor. So erosive gastritis will predispose people to low B12, and it probably can end up in people getting pernicious anemia. So if I had somebody who had erosive gastritis, was Helicobacter positive, and had a marginal B12, I would simply treat the Helicobacter, eradicate that, and watch the B12, because the chances are it will just return to normal. But if it doesn't, then it doesn't need any further investigation. It just needs B12 injections. But that's probably en route to a pernicious anemia type thing, but it would probably, for me, recover with Helicobacter eradication. And I would eradicate anybody and everybody who's found to be Helicobacter positive. Doesn't matter if you can do it with biopsies, you can do it with a breath test, you can do it with a blood test. It doesn't matter. If you're Helicobacter positive, get it eradicated, and it prevents ulcers from happening. And as I said, it's the medical miracle that nobody ever thinks of or comments on.
Okay, perfect. Thank you very much. Right, let's find out if we can find another medical miracle. PBC and low platelet counts. Is this a thing? Should we be concerned?
So platelets are cells in the blood, actually fragments of cells. They're not proper cells, but they are the little cells in your blood count that are the body uses to clot. Okay, so they clump together and they form a clot. So if you cut yourself shaving or whatever, and you bleed, it is the platelets clumping together that stops you bleeding. It's not actually clotting factors as people think. It's actually in the first instance platelets. So what happens is that if you have a cut, the air, the blood circulation is exposed to the outside air, okay, and that causes a change in the lining of the little vessel that's bleeding, and that activates the platelets, and they all clump together and they basically glue off the bleeding vessel. So that's how clotting works. So in any cell in the body, in the blood, okay, if you look at the blood cells, right, it's a balance between those cells being produced and those cells being used up. So we all have a steady state where these cells have a certain lifespan. They're used up, they die, they become old, and the body gets rid of them, and we produce exactly the number of cells to replace exactly the number of cells that are being used up. Okay, so shortage of these things, like an anemia, happens if you are losing these more quickly than you are making them. So you get anemic if you are losing blood into your bowel or into your kidneys. So if you've got low level chronic bleeding, you become anemic, not because your body isn't producing red cells, it's because it's losing them faster than it's making it. Think you're trying to fill a sink with a plug hole not in. It's going to build up, right? So platelets are used up by two things. One is by being consumed by a bleed, okay? So they get used up, so your platelet count might drop with that, but they also can sit in the spleen if the spleen is enlarged. So they can all be there in the body but are just not in the circulation. They're kind of being stored up, okay? So a low platelet count, by my model, it's either not enough production or it's too much being used up. So the common reasons why a low platelet count happens in PBC are two. One is that you have a more advanced form of the disease. So you have what's called portal hypertension. So you have high blood pressure in the vessels around the liver, which is a feature of cirrhosis. So a low platelet count with PBC can be a feature of cirrhosis. Now, we've rehearsed this many times. Most people with PBC don't have cirrhosis, but some do. And a low platelet count in PBC, the commonest reason would be cirrhosis. And so therefore, the right test in that situation is a FibroScan that would tell you whether you're cirrhotic. So a low platelet count for me would always lead you to having a FibroScan. Okay, in the old days, it was liver biopsy. We don't do that anymore. It's FibroScan. Okay, and an ultrasound scan is quite useful. And what you're looking for is an enlargement in the spleen, because in portal hypertension, cirrhosis, the platelets are there, but they're in the spleen. Now, the other reason why PBC patients get a low platelet count is because there is an immune loss of them. Okay, so just as pernicious anemia is associated with PBC, there's a thing called autoimmune. There is idiopathic thrombocytopenic purpura, ITP. ITP, there is a natural immune loss of the platelets, and it can be an associated feature. By far and away, the commonest is related to the spleen being larger. Now, unless the platelet count is below about 50 to 60, then it's not associated with a bleeding risk. So the real worry, might be that if your platelet count is low, I'm going to bleed. But unless it's very low, it doesn't mean people bleed. But if you have got a low platelet count, you need to find out why. There are a few different causes. The commonest one is to do with the stage of the PBC. But if somebody's known to have cirrhosis, has a low platelet count, it's of no significance. It's not. It's just a guide for the possibility that that's there. But it is one of these things where there are lots of different small print reasons why you could get it.
Okay, perfect. Again, that's most helpful. Thank you. Okay, back to our PBC and. So in terms of other conditions along with PBC, okay, medicines that we can or cannot take.
Yeah.
So somebody's been prescribed hydroxychloroquine tablets for their Sjogren's syndrome.
Yeah.
Are they safe to take with PBC?
Yeah. So as I alluded to, PBC is an inflammatory immune condition, and because the predisposition to it is the way in which your body controls inflammation immunity, there is a tendency for people to have more than one of these conditions. We've talked about hemolytic anemia, a thrombocytopenic process. We've talked about pernicious anemia, and we talked about PBC. They are all overactivity of the immune system. Okay, and it's quite common to also get Sjogren's syndrome, which is the form of dry eyes and dry mouth that PBC patients get. That's an immune reaction to the salivary glands and the tear glands, so that they don't produce enough. And it's quite common to get an arthritis. Okay, so people can get sort of often a small joint arthritis. It can look a little bit like rheumatoid arthritis, affects the joints in the hand, but it doesn't give you that very aggressive tissue damaging type of erosion that you see in people with rheumatoid. So it's very important to know that. That's very uncommon in PBC. It's often uncomfortable, but milder than that. Now, our rheumatology colleagues have a range of treatments. We have a range of treatments we use in PBC, urso, ochre, mesofibrate, etc. But our rheumatology colleagues and GPs who manage joint problems also have a range of treatments which have been developed and evaluated in those conditions, of which hydroxychloroquine is one of them. So it's what's called a small molecule drug. It's a tablet, if you like urso is a tablet. And what it does is damp down inflammation. Okay. The other group that they use are what are called biologicals. Those are more complicated drugs that are antibody based and which modify part of the immune system. Now, we don't use those in PBC. We use conventional drugs because they have the effects that they want. But a lot of times the rheumatologists will talk about using those biologicals. Hardly a week goes by without one of my rheumatology colleagues asking me, is this drug safe in PBC? Is that drug safe in PBC? And the answer 99 times out of 100 is yes. And so our common guidance is not to be concerned about any of the drugs you might use in Sjogren's or in an arthritis from the point of view of PBC. Now, some of them have some evidence that they are beneficial in PBC. So rituximab we did a trial of is beneficial in PBC, but we don't need to use it. Tacrolimus, cyclosporin are probably beneficial in PBC, but we don't need to use them. So a number of these drugs are useful in PBC. The ones that aren't useful in PBC, either we don't know, but certainly we know from experience that they're not harmful. So every time somebody has one of these, we are told about it, we watch them, we follow it up, we collect the information. And I have never seen any problems with any of these drugs in people with PBC because they've got PBC. So we give guidance, if you're going to use a drug, use one that's sort of got some evidence it helps PBC. Why not? The drug doesn't know it's treating, the joints, not the liver, so you can get a double benefit from it. My only observation about hydroxychloroquine, as I say, this is not about individual advice. My own observation is it causes quite a lot of side effects in people, not related to PBC, but it's just not a drug that people come in and say, I'm on hydroxychloroquine, it's going really well. So it's a bit old-fashioned, and it's just something that, I chat to all my patients, as people know, and it's just something people kind of just don't think is brilliant, but that's not to say people shouldn't take it. It's just a general observation. So they tend to move on. And I think one of the questions I would tend to ask in that situation is, are you using hydroxychloroquine because you're worried about using something else because of the PBC? This is to the doctor, because chances are you don't need to be. So the biggest risk with drugs in PBC is not side effects of the drugs. It's the fact that people don't get the drugs they need because the doctor is worried about their PBC. Almost without exception, you don't need to be worried about drugs with PBC. And if you do, all you would ever do is simply suggest that you measure the blood test a little bit more frequently. So and we do that with people just to reassure everybody. So get the right treatment for the other problems, make sure that the PBC isn't impacting on the decisions that other people are making. But hydroxychloroquine, 6 out of 10 in general.
Perfect. All right, brilliant. Thank you. So the next question is now about creatine supplements.
Yeah.
So it's out there that they help with autoimmune disease, that they help with muscle energy. So somebody is hoping that they might help their own fatigue. So the question is, any thoughts on this? Are they safe to take with PBC? Is there a suggested dose?
So I have no experience of them. People will be aware they are kind of somewhere in the hinterland around food supplements, vitamins, but not drugs. What's a drug? It's to do with its licensing regime. So there are essentially 3 classes of drugs. One is drugs that are prescription only. So they have to be prescribed by a doctor. Another one is pharmacy only. So you can get them in a pharmacy, but they're the ones that are behind the counter and you can't go and get them in the shelves. And another one is things that are on open shelf display. So these are the ones you could get at Boots, but you could also get at Tesco's. Other supermarkets are available. So, those are the things you can go and pick up. And there's a journey over time. So I was talking about those very potent ulcer drugs like omeprazole. When they first came out, they were prescription only. You now get them literally on the shelves in Tesco's. So as people get familiar with the drugs, then so they tend to usually be lightened up a little bit. Sometimes it goes the other way as people start to realize there are side effects with them. And sometimes the same drug can be in different categories. So 200 milligrams, packets of 16 200 milligram tablets of Brufen are a supermarket accessible treatment. You can go and see them in the medicines aisle in a supermarket. 400 milligram tablets you have to get from a pharmacy from behind the counter. And if you want to get more than 16 tablets, you have to get them from behind the counter at a pharmacy. So there's a regulation around all of this. For food supplements, there is no regulation at all. You can literally sell whatever you want. And also, interestingly, there is no legislation around claims. Okay, so if I prescribe a drug and say it's going to transform your life, that's very much legally controlled. It has to be based on the evidence, and you have to be able to point the evidence forward. If I say that this food supplement is going to change your life, that the only way in which there is any comeback with that is under the Trade Descriptions Act. Okay, so it's about an inaccurate marketing claim. So it's a much grayer area, and therefore you don't really get a lot of the evidence, and you don't get a lot of trials because, in a sense, that it's odd because you don't have the regulations to follow. There are no regulations to follow. Okay, so these are the sorts of areas where there's very little information. Now, we did a trial of coenzyme Q10. It's about the only vitamin trial there's ever been in PBC, which showed some benefit for fatigue, and that's one of the reasons why we use it. So there is very little information. So creatine is used by bodybuilders, so it's used by people to increase muscle activity. So it partly builds the muscles up, it partly increases the amount of energy that people have got to be able to weight train. Right. So what's that got to do with PBC? Well, people are fatiguing too quickly with PBC. So there's a theoretical reason why it might be advantageous, but it is only theoretical. I have no experience of it, and I wouldn't be able to comment on the dose. My instinctive feeling is that there's no risk with it. There's no safety issue. There's no reason theoretically why it is, and as I said, I've got no experience of it being used in practice, so can't base that. But I don't instinctively feel there is likely to be a problem, and I would say that to somebody in the clinic. So, theory, yes. Potential, yes. Data, no. Personal experience, no. And use with caution would be the advice. We talk often about what organizations like the foundation can do, and there is a concept which is growing around what we call crowdsourced research. Okay, So, and here's a wonderful example. Does creatine help with fatigue? Well, the foundation has 16,000 members, so there are bound to be people who are taking it. I mean, people go on the internet, read the literature, are bright and think about these things. I've got no chance of collecting any information on that because we don't know that people are taking it, but the PBC Foundation could do. And if you had 10 people on the app, plug for the app, use the app, it's really helpful. It's the future. If we could find 10 people who've taken it and we could collect their experience, that would be the most comprehensive information in the world on this. Okay, it's not a trial, it's not a perfect piece of research, but it's a hell of a lot more useful than nothing. So this is one of the powers of a community of people sharing their experiences, because it's where, believe me, it's where innovation comes from. If those 10 people say, I thought I was the only one, all of a sudden I could do far more. If one person says that, it's difficult to know the significance of it. If 10 people say it, then it starts to become interesting. And then it becomes possible to do research around it and to put a little bit of kind of meat on the bone, no pun intended. So that's just a plug for collecting this information, because it's not the sort of thing that is captured by any form of medical record or any form of normal research, but it will be out there. So it is a way, and just remember that there will be people very familiar with thalidomide and the tragedy stroke scandal around thalidomide in the 60s. That wasn't research that found the effect of thalidomide. It was collecting information on people taking it in the real world after it had been approved in trials. Trials did not show the problem. It was collecting information from people taking it in the real world that did show it. So there is a precedent for this being a very powerful tool. And nobody would argue that that wasn't as good as a trial showing those side effects. It transformed practice. So it's a really interesting way. And I think these questions are crowdsourced research, just as a useful concept.
Okay, perfect. Thank you very much. So here's a question. I was diagnosed with PBC 4 years ago and have not been put on Urso.
Mm-hmm.
Had bloods taken recently and told that they're priority for a hospital appointment due to concerns with blood tests.
Yeah.
Was told by the hospital that I may have to wait months for a priority appointment. Is there anything you can just suggest to speed things up? So I know I've got my thoughts, but I'd be curious in yours.
So, so PBC starts simple in terms of management, but then gets more complicated. Okay, so we do have a concept, and Robert talks about it all the time, around personalized treatment, which is exactly what we should do. So for you as an individual, you need to have the treatment that's right for you based on your mix of problems, severity of the disease, side effects of treatment, symptoms, complications, other conditions. And no two people are the same. Okay, so everybody is an individual, and you need to weigh up the needs of that individual. Now, the starting point, however, is always the same, which is Urso. Okay, so UDCA is the starting point. That's the entry to everything else in PBC. And we became very worried about this in COVID, that because the system wasn't working, people weren't embarking on a pathway of personalized medicine, even though the starting point was the same in everybody. So when we see somebody with PBC, we start them on Urso. And the next big decision is a year down the line. Okay, so actually there is a delay because you need to see how effective Urso is. Now you need to ask about symptoms and other things, but the key first step is Urso for a year and see what happens. So clearly it's not in anyone's interest to delay the beginning of Urso, because you're just adding time to any further therapy being necessary. And Gideon, who everyone will know, and myself coined a concept called first aid for PBC. Now, it's a slightly a misnomer because, you know, in a sense, there is no first aid. It's not like putting bandages on people. But what can any doctor reasonably do with PBC pending a definitive answer? And we arrived at urso and cholestyramine for itch. Okay. And why are those reasonable? Because they are the first line treatment for itch, first line treatment for PBC, and both are incredibly safe. They need no specialist knowledge and they need no specialist management at all. No screening, no blood test to follow it up, no nothing. It's just a prescription. So I feel very strongly about this, is that there is no need to be seen in a hospital to be started on urso. You need to be seen in a hospital after you're on urso to work out what, if anything, you need to do next. And that would be my advice, is that to go back and say the view of the PBC Foundation. So, you know, Robert is the chief executive. I am the chair of the medical advisory board. If you took all of the medical advisors, we brought all of them onto this call, they would all say exactly the same thing. Just start urso and do all the rest of the working up down the line. And it's how you go about that. But I would go back and I would say that doesn't matter if you've got abnormal liver function tests and a raised AMA, the treatment is urso at 13 to 15 milligrams per kilogram, and it doesn't need a hospital visit for that. Now, if the GP refuses to do that, I'll be interested in what Robert says. You know, there are other options, walk-in centres, for example. Okay, so you can just go to the local walk-in centre and tell them exactly what we've talked about. All you need to do is to get on the urso pending it. I mean, at the end of the day, you know, what I would say in these situations is, are you sure you're with the right GP if people aren't prepared to offer basic treatment? But that takes a little bit of time to work out. So I would enter into a discussion. You do not need a hospital appointment before starting urso. That has been very clearly worked out by the PBC community. It's first aid for PBC. All the rest of the working up can happen on urso. And that's an entirely normal and reasonable thing to do. And there's no point waiting 6 months to get what we would just do automatically without knowing anything more. Now, it is important to say, however, that the risk of waiting 3 months is pretty low, and it is important to say. So the reason why there's no first aid for PBC is because it only progresses slowly over time. So it isn't the end of the world, but it's not ideal. So don't worry about it. This does not progress quickly without treatment. The treatment works slowly and over a long period of time, but it's also just a bit indicative of not taking it seriously. What would you say, Robert? You must encounter this as an observation all the time. It drives us mad.
Yeah. So, yeah, I think so. We have a lay document. So this is the European one. There is an American equivalent. Okay. So this is a translation of the EASL Clinical Practice Guidelines. EASL being the European Association for Study of the Liver. So these are guys who kind of have a rough idea of what they're doing. And they have produced a guideline, which is the diagnosis and management of patients with primary biliary cholangitis. And one of the key recommendations is that anyone with PBC should be offered urso at the dose that Dave mentioned. So we have this, we have the American equivalent. It's on our website. You can print it, you can download it, you can take it to your GP and use this to have the argument that this is a basic care right of anyone with PBC.
Yeah.
Dave alludes to, it's first aid.
Yeah.
So I would offer that. I would offer also, and this goes for anybody who's asking any question today or in the future, give us a call. Let's talk this through in detail and let's find out how we can help you in a way that's helpful to where you are today in your PBC journey. And that's as much as I'm going to say without the swear words.
Yeah, and I think it you know, in a sense, cut a little bit of slack if you like, which is that we'll forgive the GPs for not really being aware of current thinking. And to be fair, the PBC community itself has not helped itself. I mean, by that, I do not mean the patients, I mean the doctors, by having endless pointless arguments about whether URSO works or not. And it's not been the most edifying thing. And there are still people who question whether URSO works. So that is out there. And anybody who's kind of heard any of that may think there is still a debate going on. So something that we've talked about, we talked about it with that crowdsourced research concept, which is there's a thing called real world evidence, okay? And a clinical trial, so the original URSO trials were on 200 people, okay? And on that basis, URSO was used, but it was quite grey. The effect wasn't clear cut. And so there was debate based on the fact that these were trials, in a relatively small number of people. However, the global PBC group that a number of people will have heard about, which is coming together, which has brought together information looking backwards in about 15,000 people. And then you've got the UK PBC study, which looks forward. Many people are part of that, which is in about 10,000 people. So about 25,000 people around the world, we've been able to look at what URSO does, okay? Not 200 in a trial, 25,000. And what that shows, beyond any shadow of a doubt, is that URSO is beneficial in PBC. And it also shows that it is incredibly safe. And the more people you study, the more, were those 200 people really representative, or were they kind of a little bit different or something like that? 25,000 people, that is completely representative. And so that data shows beyond any question that URSO is very effective and is very safe. And it also shows, to a lower level of certainty, that it is important to be at 13 to 15 milligrams per kilogram. If you're below 13, it's not quite as effective. But don't get me wrong, URSO at a lower dose is much more effective than no URSO. So there is no debate anymore about URSO at all. The only aspect of URSO is the realization that it is not definitive for everybody, and there are people who need URSO plus something else. So the treatment decisions in PBC are URSO or URSO and something else. It is never, should I have URSO or not? And I think we'll cut the GP some slack, that they are maybe familiar with some of the debates that happened a few years ago, and all they need is just a little bit of awareness raising. And Robert's pointed out that document's really important in the nicest possible way. This is kind of, what we as a learned, as a group of patient advocates, patients, clinicians, scientists. And, the daft thing is, all the companies interested in developing new treatments for PBC, they'd also say the same thing. They'd also say, go on to URSO. So everybody agrees about all of this. Now, I think we can cut a bit of slack. They don't maybe appreciate, and you've, in the nicest possible way, given the information. If they then choose not to act on that, I think that becomes a more significant thing. I think that's starting to be quite problematic. And I think they need to be very careful, because if somebody and don't take this the wrong way. Most people with PBC have absolutely no problems down the line, but we know that, for example, URSO reduces itch in PBC. Okay, it's not huge, but it stops the onset of itch. Now, if you don't go off and get itch down the line and weren't treated with URSO, that doctor cannot prove that it wasn't caused by you not getting URSO. And I can make a case to argue you should have got URSO. It's the recommended treatment. It stops the onset of itch, and so therefore you've got itch because of that. Okay, and as Prince Harry is discovering, it's very difficult, when you haven't got a really good reason for doing something or not doing something, it starts to look pretty bad pretty quickly. So you are helping them by pointing out what the absolutely established thing is. And again, what's the legal test for the right treatment? It is, what would a reasonable expert in this field think was reasonable practice? Now, what from what I've said would indicate that not giving URSO is regarded as reasonable. So they are ignoring established practice by not doing it. Don't fall out with them. smile very nicely and say that you are engaged with a very proactive patient group with medical expertise, and the consistent view is as outlined in Robert's document. And I think hopefully a sensible doctor would think, okay, I'm going to prescribe urso. But we're finding it increasingly difficult to get GPs to prescribe things, to do blood tests, to do, and I have a rule of thumb that, the number of times we get letters from GPs, about why they're not doing blood tests on principle, which take 10 times as long as it would have done to do the actual test. And I don't know why that is. It's just unhelpful. But I think Robert's point is good. These are well-reasoned arguments. There's no ambiguity. We're not expecting them to prescribe drugs that are difficult, dangerous, toxic, need monitoring, need adjusting, need blood tests. It's like giving kind of paracetamol, but slightly less risky, if you know what I mean.
So, all right, thank you. We are now entering, we bypassed that line, but we're in the quick fire round, if that's at all possible.
Robert always tries this around this time, for those of you who are new to this, and it's a few times, as you probably detected.
So, okay, so we've got one question a minute. So here we go. I have cirrhosis and varices. Had a 13.5 random glucose blood test, HbA1c test. Who would call a test HbA1c? But anyway, told not diabetic, but they have read research that if you are cirrhotic, you can get a kind of false normal HbA1c result. So, any advice? Any thoughts?
Yeah, okay. So, important caveat, cirrhosis is uncommon in PBC. That's really important, okay?
Yeah.
The whole ethos of everything we do is to prevent cirrhosis from developing, but there are people who develop cirrhosis. Often they develop it, because the disease isn't picked up early enough and all of that. So that's just a caveat. So where people get cirrhosis, you get specific problems, and this really is an area where you need individualized treatment, because no two people are the same. Now, the really important thing is people with cirrhosis with PBC do really well with it, so it is usually not problematic, but it needs attention to detail. So it's what proper hepatology clinics deal with day in, day out. So that's the first thing to say. If you've got cirrhosis and PBC, do not panic. This is a perfectly controllable, manageable, treatable state, but we need to work out what you as an individual need exactly. Okay, so that's important. So one of the things that can go funny in, and that, there's a technical term for you. This is not. Why do you always introduce complicated questions in quickfire round? By the way, Robert, is that's just you. Anyway, so one of the things that goes a bit funny is glucose metabolism. Okay, and the reason is that when you eat a meal, your body produces insulin that tells your liver to lay down the sugar as a thing called glycogen, which is a storage form of sugar. And then in between meals, when the sugar drops, because you haven't eaten a meal, it releases the glycogen. It's like that mountain in Wales where they pump the water up. And there's one in Scotland, I think, where they pump the water up at night when nobody's, got the kettle on. And then when Coronation Street reaches its break, they let the water down, power the turbines, generates electricity quickly. So it's exactly the same principle. So people always think that sugars go wrong because insulin levels are funny, reduced in diabetes. But of course, it's equally true if the liver is not functioning normally. Okay, so it is common to get glucose changes in cirrhosis. Now, normally it's low glucose for the simple reason that people do not feel like eating, and so they haven't got the store of glucose. Cirrhosis makes you feel a little bit sickly, and so people tend to run a low sugar. However, if you are eating normally, remember this laying the sugar down, glycogen blunts the level. So it's like this coming out from the gut, but it's like this in the rest of the body because those peaks are cut off. But if you've got cirrhosis, those peaks aren't cut off because there is a reduced amount of liver tissue. So a glucose of 13.5 isn't problematic in cirrhosis because it could just indicate a spike. And if you were to kind of reduce that by eating less, you would be going hypoglycemic the rest of the time. Now, in fact, HbA1c is the test to use in cirrhosis because it averages your glucose over time, right? So basically, this is where hemoglobin gets modified by glucose depending on how much glucose is in the blood. And so it's an average of what your glucose is over the last, basically 3 months. So if you want to know if you're diabetic or not, it's HbA1c regardless of it. And the HbA1c is normal, you're not diabetic. So how can you be not diabetic and have high sugar peaks? Because of having cirrhosis. So if I saw somebody who wasn't diabetic and had a high sugar, they're either becoming diabetic or they've got cirrhosis. So do you treat that high sugar? No, not unless you are symptomatic with a high sugar. So you might get, water infections and things like that, but you do have to be cautious because the danger is that you end up going too far the other way. So HbA1c, it is glucose linked to hemoglobin, is in fact the test that's make this a lot easier because it rather than individual peaks and troughs, it does measure the previous 3 months. So go on the HbA1c, don't worry about the 13.5 if the HbA1c is normal, but just keep a check on it.
Okay, perfect. Thank you. Bile secretion between bowel motions. So somebody frequently has bile coming out on its own.
That's okay. Bile, you get mucus production by the bowel. A little bile goes a long way in terms of staining things. So I wouldn't be unduly worried about that. I mean, if the bowel frequency is high, that might be an issue. But if it's just a little bit of bile staining, I wouldn't be worried about that.
All right, perfect. Thank you. Shingles, vax, and PBC. Any implications?
No. Shingles is pretty horrible. Vaccinations with PBC are typically fine. No problems. The vaccination isn't affected by PBC, and PBC isn't affected by the vaccination. So if it's the clinically the right thing to do, I would have no question. We wouldn't advise people one way or the other.
Right. Okay. Perfect. Thank you. Can the menopause impact PBC?
Gosh, that's a really good question. And if Kath Houghton, for those of you who don't know, Kath Houghton's our specialist nurse, she would now tell me off. And she would tell me off because I've been meaning to write a leaflet on menopause and PBC to give out in the clinic.
Perfect. Oh, article.
Right.
So Alan was actually going to come to you on that topic. So.
Okay. All right. Okay. So everyone's nagging me back, basically. So, and just a little plug, there is an educational webinar being put together. So our colleagues in Advans, who have taken over from Intercept, they're the company that market OCA, do patient educational webinars. We've done one on fatigue. We've done they're just openly available to anybody. They're not anything to do with the drugs. They're not commercial at all. They're just educational, and they are. We're busy, and I think it's a great thing. They're online. We'll be able to get the link for it. But their next one is going to be on pregnancy and PBC, and female reproductive questions and PBC. And the person, this is just a plug. The person doing that is going to be Catherine Williamson from King's, who, for those of you who don't know her, is probably the world's leading expert on this, and is an absolutely lovely person who has looked after a number of our patients with concerns around all of this. So that will be absolutely fantastic because it's an area where we probably underestimate the importance. So about the menopause. So menopausal symptoms are not commoner or more problematic per se in PBC than in anybody else. However, given that 90% of PBC patients are women, they are a feature. And I think it's becoming increasingly clear to us that menopausal symptoms add to the symptom burden that people have. So if people get brain fog from PBC and they get brain fog from the menopause, it's additive and it makes the whole situation worse. And of course, it may well be that the menopausal side for this is easier to treat. So is brain fog in PBC just menopausal symptoms? No, absolutely not, because brain fog affects men with PBC, and it also affects premenopausal women. In fact, it's worse in premenopausal women than it is in older women. So it's not the whole story, but it's part of the story, and it's an easily treatable part of it. And remember what I said about medical research often being wrong? There was a mythology that you shouldn't use HRT in PBC. I was, brought up on that. And there is no evidence basis for it at all. And I think a lot of people are erroneously told they shouldn't take it. We've started using it much more. And I have to say, it helps with the overall symptom burden. So I think the message is you do need to just be a little bit careful with the preparations you use. That's into the article that I'm clearly about to write for the Bare Facts from the hinting that went on. And Catherine will cover that. So I think there's some nuances about it, but I think it's underused. The one thing I wouldn't use HRT for in PBC is something we used to do, which is to protect the bones. There are better treatments to do that, but I think for overall symptom burden and quality of life, it's something that is well worth considering, and it's something we cover in our symptoms clinic quite a lot, and I think a lot of people have had real benefit from it. Just to say, there's a lot of stuff out there in the lay press about the quotes risk of HRT. It's a little bit overstated for me. Okay. And the reason is that, an awful lot of people take HRT. And so it's easy to show, you'll find, I'm sure there's somebody who takes HRT who's been struck by lightning. It doesn't mean that HRT makes you more likely to be struck by lightning. You can pull these anecdotal stories out and make an association that isn't there. So I think you need to look at individual risk around, history of cancer and history of clotting in you and in the family. But I don't think that's any different to PBC patients in general. You do have to weigh the benefit up as well. So it's a good point.
Perfect. Thank you. Younger patients with GP210. Yeah. There's information out there that says they're more likely to reject a graft after transplant. Is there? I don't know. Can you tell me?
GP210. So risk is not symmetrical in PBC. Okay, so that there is a range, a spectrum of risk of progression of PBC. Now, the younger you are, the more years you will need your liver. That's kind of obvious. So, if you want to live to 80 and you're 30, you need 50 years out of your liver. But if you're 79, it's only a year, right? So there's an element of common sense to that. The younger you are, also, the less likely you are to respond to URSO. Now, that's an observation. And we know that not responding to URSO is a risk factor for disease progression. Now, young people are not at greater risk of progression to cirrhosis other than through this reduced response to URSO. So it's risk of a risk. That's really important. So whether or not you've responded to URSO remains the most important risk factor if you're young. It's just that you're more likely to not respond. If you've responded, you're still low risk as anybody else who's responded would be. So that's the first thing. It doesn't change what we do. GP210, across my mythical 1,000 people with PBC, GP210 is associated with a slightly higher risk of not responding to URSO and progression. However, it is not a clinical test that we routinely use because the majority of people who don't respond to URSO do not have GP210, and the majority of people who have GP210 respond to URSO. Okay, so it is just one of these slight weighting factors. So if I had a young, we look cautiously at all young patients, okay, because you just need more years out of it all. And would I look more carefully at some of the GP210? I would be aware of it, but I'm still obeying the basic rules. So the basic rules are get the URSO under control. Robert will tell you a theme that you will hear increasingly in these sessions until it becomes a crescendo is that we are going to become over time more ambitious with our targets for liver blood tests, and we are going to be looking for normal tests. If I was 30 and I had GP210, I would want my blood test to be normal, full stop. And that's going to be the direction of travel. Would having GP210 change that? No, it's the fact I was 30 I'd be more worried about. Does GP210 mean you're more likely to reject the liver post-transplant? I'm not aware of that. I've certainly not seen that in practice. And rejection is not a particular problem with PBC patients post-transplant. So it's more to do with other factors around. So the big risks for having a liver transplant are much more to do with the quality of the liver and the blood donor and blood donor status and all of that. So transplant is very straightforward. Recurrence of PBC and rejection are not major factors that influence our decisions about it. So younger people, you just need to be aware and be tighter in the control, but none of that is anything other than common sense. But sometimes people can say, oh, they're young, they've got years, they won't have a problem for years and years and years. That's just the wrong way to think about it. It's attention to detail is important to everybody, but the more years you need from a liver, the more important it is to get it right. Yeah. That's the same ethos with managing type 1 diabetes, by the way, that, that in the old days, as long as you weren't falling over with hypoglycemia, that was fine. Nowadays, they want your sugar between 4 and 6. Why? Because 20 years down the line, it will make a difference.
Indeed, thank you. I'm going to try and squeeze in 2 more questions, if I may. Number 1, so we've got somebody, so interestingly enough, we were at the Canadian PBC Society conference at the weekend, and Gideon in his presentation talked about aspiring for normal to be the new normal, which was interesting. So we've got somebody here who is got normal tests, including AMA negative, now that they've been on URSO for a few months. And I guess they're just slightly concerned in terms of, how does that happen and what does it mean?
So somebody's essentially become URSO negative, become AMA negative.
But also their normal tests as well. Their tests have all normalized.
Okay. So that's an interesting one. So that's unusual. Okay, that's unusual. So normally you have AMA for life once you've been AMA positive, and in fact we would tend not to remeasure it. It doesn't matter. It doesn't mean the disease is worse if the level goes up. It doesn't mean the disease is better if the level goes down. So it is a marker of PBC. It is very unusual for it to disappear. Okay, but disappear it has. Normalization of the liver function test could be one of 2 things. It could be you responded really well to the URSO, or it could be that the PBC has gone away. Okay. If the AMA disappears as well, then it's unlikely to be the effect of URSO. It doesn't work in that way. So the question has to be, has the PBC gone away? Does PBC ever go away? So I've looked after probably about 1,500 people with PBC in my career. And I would reckon over that time, in about 20 people, PBC has gone away, where they've had clear-cut PBC, including, and Robert, put your fingers in your ears and go not listening, people who'd had a biopsy to confirm their PBC in the bad old days. Biopsy proven, abnormal LFTs, AMA, all goes away, okay? About 20 times out of 1,500. So it's a tiny fraction, but it does happen. So what's going on there? Well, we think there's an infectious trigger for PBC, probably, a virus of some sort that gives the immune system a boot. And if you've got the genes that predispose to PBC, your immune system is ready to be booted, if you like. It's possible that in some people, the kind of immune system is not particularly susceptible, but they've had a big boot, and so it triggers it, but it's then not sustained. So I always use a Zippo lighter analogy. So Zippo is the old petrol cigarette lighter. You both need the petrol and the spark, and if you have both, you get a sustained flame. But if you have only the spark or only the petrol, you don't get. But also, the petrol runs out at some point. So what would I do with this information? So it is possible that you're just somebody in whom the URSO has made the AMA go away. AMA doesn't cause PBC, so it's perfectly possible. But it's also possible that the PBC has gone away, it does do 20 out of 1,500, remember. So what would I do with this information? Well, there are two things you could do. One is just ignore it completely, keep taking the urso and be pleased your LFTs are normal. If it ain't broke, don't fix it. You've had a perfect response to the treatment. Urso has no side effects. It's very safe long-term. It has no problems. What's not to love about that? Carry on and just be, keep having your liver blood tests checked and just check they don't go abnormal. Okay. And that would be what I would do. If you want to know whether the PBC has gone away, what you do is stop taking the urso and find out what happens. And one of two things will happen. You'll stay normal and the other one is that it will recur slowly, in which case you go back onto the urso. How badly do you want to know that? I don't know. One of the questions would be how long between the AMA and starting urso. If you've had it for 10 years, it's unlikely to have gone away. Those 20 people who got better, it was all really sudden onset. It all happened very quickly. And so it was kind of, they'd had an infection, been found to be AMA positive abnormal LFTs, had a biopsy, and then this all happened over the space of a year. So this has been going on for a long period of time. It's PBC and it's just behaving in a slightly strange way. Alternatively, it's all happened quickly. But ask yourself, how badly do you want to know? Because the only way to find out is to cause the disease to come back. And that seems a little bit like a Pyrrhic victory, but it's unusual. It's possible it's gone away. Personally, I would be pleased and carry on with the urso.
Okay, perfect. Thank you, sir. And do you have time for a very quick question on fatigue?
I've got a hard stop at 3:30 to be on another important call.
So you and me both. So, okay,
This is important. Additional important call.
No, I appreciate you. Thank you. The question is about that brick wall moment. So we hear this often. It's the fatigue just hits you.
Yeah.
And people have described it as the power being pulled out. They talk about walking through treacle or walking through custard, wearing a light blanket or hitting that brick wall.
Yes.
So how do we talk about that? How can we support patients in that? Do we understand why it happens and what they can do about it? A nice easy one to finish off on.
Yeah, so I mean it's really interesting. I mean, as people will know, we're doing this work around how to quantify symptoms in order to do trials moving forward of symptom treatment. So very, very important. And I think this is one of the things that comes out again and again and again. The words around it are very powerful. This abruptness of the impact that people get. Okay. It's very interesting. A lot of the research that we did around this was followed on from the words of patients. Words are very powerful. And it was this sense, I remember vividly the lady saying it, that she felt like she'd run half a marathon and hit the wall. But she'd only been walking to the supermarket. And what was very interesting is that people who exercised a lot recognized this, but what they didn't understand is why it was happening at a point inappropriate for the amount of exercise they're doing. And we went on and did some work, looking at people's muscle function and things like that around it. And interestingly, what was happening in people's muscles was exactly the same as would happen after a half marathon. When somebody said they felt like they'd run a half marathon, their muscles were behaving like they'd run a half marathon. Okay. And this is at the focal point of what we do in the symptoms clinic, is to try and mitigate that effect. So what happens when you, quotes, hit the wall? So what's happening is that you have basically run out of accessible energy in your muscles. We talked about glycogen. So glycogen is the water pumped up the mountain during the night to be released during Coronation Street. You have glycogen in your liver to fuel the body, but you have it in your muscles to fuel your muscles. And so when you do a half marathon, if you've trained really well, then what will happen is you'll be able to do that all day long because you burn fuel in a much more efficient mitochondrial way. But most of us don't do that. And so what you end up doing is consuming all your stores until eventually your stores have gone. And at that point, your muscles pull up the drawbridge and say, we can't function anymore. So that's what's happening in PBC patients. So you are basically reaching the end of a fuel supply that you are burning in quite an inefficient way. So what will help with that? So this is very practical advice in the short term, and then a little bit of more medium term. So in the short term, it's lactic acid building up in the muscle. So drink plenty because it will help wash the muscles out. So drink in order to get flow into the muscles and flow out to carry the acid away. Okay, so drink a litre of water. Okay, so this is much more of a problem if you get dehydrated. And then the other is the problem is a basic lack of glucose in the muscles. So as somebody who went hypo with a sort of diabetic situation, eat a Mars bar, other confectionery is available. So get a sugar load in very quickly. Acutely, if you've really, really hit the wall, drink a litre of water and eat a sugary snack. And you will find that the acute sense may well disappear. More chronically, then what you need to do is to carry on drinking lots of water to reset the circulation a little bit. But the two things that you can do is to do more exercise. This is how movement as medicine works, because you train your muscles to operate in a more efficient way. Now, that's not going to help you if you're just hitting the wall and halfway around Sainsbury's, but it will help in the medium term. And this is where the vitamin coenzyme Q10 that I mentioned that we've done trials on, that's why we suggest that, because it helps smooth out these energy on and energy off. But if you've literally hit the wall, drink a lot of fluid and eat a sugary snack, and that will ameliorate it. But think about drinking more on a regular basis, just water, and think about exercise and think about coenzyme Q10. But it sounds like somebody hitting the wall in a half marathon, because it is the same exact biological process. And the reason you feel tired is because your muscles are struggling. They send a signal to your brain to say, stop exercising, because otherwise you're going to cause real damage. And that's sort of, it's like an emergency switch which is flicked.
Wonderful. And as if, there you go, I've been exercising an hour a day, drinking 96 ounces of water, and can't believe the difference it's made in my fatigue. There you go.
And genuinely, that is not a setup. Okay.
No, of course it's not. So
not a setup. And the fluid is really important because it washes. Lactic acid builds up in your muscles and your muscles hate it. But ironically, your heart loves it. Your heart consumes lactic acid all day long as a fuel. So what you need to do is to get the lactic acid out of your muscles and into the circulation so your heart can burn it. Okay, and you get it out of the muscles, it needs to be transported out from the cells into the circulation. And that's done by transporters, which are increased by exercise. That's how exercise training works. And then they are carried away by the circulation, and increasing your circulating volume by drinking water carries the fluid away. So it is getting lactic acid simply out and into your heart to be consumed. And we showed in some of our research that exercise training reduces the extent to which you get acid build up in the muscle. So it absolutely works. But all credit to that participant who gave their experience. It's not easy to do that, but boy, does it work. And I'll just finish with a concept called secondary gain, which we talk about all the time. So primary gain is where you do something essentially because I, as a doctor, suggest it's a good thing to do. Now, you may not believe or trust me, okay, that's up to you, but you are taking something on faith and you will do it and that's why we explain the mechanism, because that's easier for you to understand, but you're still going home to think, I'm going to do something different because somebody has suggested it's a good idea. Secondary gain is when you feel better because of it. So the things that I said would happen, happened, and you felt it. And at that point, you no longer need to believe me because you can believe yourself. So you don't need to believe me forever about exercise. You just need to believe me about exercise and fluid till the point at which you feel it yourself. And that's secondary gain. And it's so important with all behavior changes. It's like going on a diet. Somebody says, eat less food, go on a diet, you'll feel better. You feel miserable and you hate the doctor. Then after a while, you feel better. And that's the point to which believing the doctor doesn't matter.
Perfect. Thank you very much. Again, exercise doesn't always have to involve Lycra. We're talking about meaningful physical activity. And, give us a call and we'll happily talk that through.
And as I always say, one of our colleagues who invented the term movement as medicine, very, very good term. I asked him what constitutes exercising, and he said doing 10% more than you do now. And I think it's a brilliant line.
Indeed. Brilliant. Dave Jones, OBE, thank you so much for today. I appreciate it. We've run over as ever, but I'm grateful for your answers.
Brilliant. I mean, what can I say? Brilliant. Absolutely brilliant questions. And thank you for that comment about exercise and fluid. That is, I can bang on about this all day long, but that's somebody who's done it.
Yeah, okay? Absolutely. Wonderful. Thank you very much, everyone, for joining us today. We shall see you soon.
Okay.